Hello, this is Sebastian Sattui from the University of Pittsburgh, and this is my QD clinic for today. And we're going to be talking about a patient I saw some time back, a few months back actually, who came to me as a second opinion. So, an 86-year-old um, female who had been diagnosed with PMR 3 years back, initially presenting with the as per kind of the note and her report, shoulder pain, hip pain, and stiffness. And at that point, the patient had been started on around 15 or 20 milligrams of prednisone, had been doing fine. But every time steroids were attempted to be tapered, things came back. And with the pass of time, things changed a little bit with some involvement of swell of peripheral joints. So patient never went below a dose of 5 milligrams of prednisone, as she clearly said. Every time I go down, the stiffness comes back. And the past year or so, I've been having significant pain and swelling of my hands, wrists, fingers. I cannot make a full fist. I'm having issues with my home chores, which I enjoy doing. Um, so at some point, I think the patient had been tried on methotrexate, which actually had led to some elevation of her LFTs, and that was discontinued. And the flunomide was not tolerated further, and there were no kind of other steroid sparing agents that were tried. So at this point, the patient comes in and tells me, "Well, I have this PMR. It keeps going on. And what can you do for me?" And the patient was clearly having significant pain and stiffness with limitation in her daily activities, but also had very profound synovitis of her bilateral wrist and MCP joints as well as some PIP joints. And as a matter of fact, those were the areas that were more painful and limiting her daily activities. As well, she complained about her neck pain and complained about shoulder pain, but her hands were pretty significant and were limiting her daily activities of daily life. So interestingly, as much as yes, shoulder and hip symptoms had been her initial manifestations, there were some other new symptoms going on. And going back into the available records and reviewing some of her images, although no erosive disease had been noticed, there were some and there was at some point some concern for possibility of CPPD disease that could be explaining some of her peripheral symptoms. There were no other serological tests that had been done. And it's sometimes important to differentiate, because certainly what used to be called the early onset RA, which should be called late onset RA, can present with a different kind of picture than what we usually expect compared to RA as we all know and kind of see in kind of younger adults. It can sometimes present with a predominance of bigger, kind of larger joints with not a typical kind of small joint pattern. RF and CCP had not been checked on this patient, and upon initial assessment in our clinic, these were checked and they were kind of over the charts. So patient was both RF and CCP positive, was having pretty predominant small joint symptoms as well as the large kind of hip and shoulder and pelvic girdle symptoms that had initially presented with her disease, with a difficulty in tapering prednisone. So at that point, as much as PMR, and that was kind of what she was coming for, we talked about and discussed the possibility of a diagnosis of seropositive RA, and started discussing about treatment options, going to the choice of a biologic agent, given that she had previously non-tolerated CST marks. Patient was started on a biologic agent after discussion with improvement of her symptoms. So this points out again into somehow teasing out the fact is that there is a need sometimes to kind of reassess things, especially with diagnosis of PMR, which although can be very classical and have this usual presentation within of if symptoms and findings change on exam, there's always room to take a step back and reassess. So thank you so much, and I hope you have enjoyed this QD clinic.